Every ICU nurse in the country has done it thousands of times. When a central line lumen is not in use, you lock it. Saline goes in, the cap goes back on, and no one thinks twice. It is one of the most performed, least examined interventions in critical care. But what if that default is costing your patients? A new randomized clinical trial published in JAMA asked whether replacing standard locking solutions with 4% tetrasodium EDTA could reduce the burden of central venous access device complications in adult ICU patients. The answer is yes, and the number needed to treat is 20. Welcome back to This Week in Pulmonary and Critical Care Medicine. This week, we cover a practice-changing trial on central venous access device locking solutions, the largest network meta-analysis to date on anti-inflammatory therapy for non-cystic fibrosis bronchiectasis, and a comprehensive clinical review of invasive candidiasis in the critically ill. Your patient is on day 4 of the ICU. Triple lumen central venous catheter in the right internal jugular. The resident pages you because the line is blocked and nursing cannot flush it. You then order alteplase. That call happens every day in every ICU in every hospital, and sometimes it ends worse than a block line. It ends with a central line associated bloodstream infection, a catheter pulled emergently, and a new line placed under pressure. We have accepted this as part of ICU care. This trial suggests we do not have to. Tetrasodium EDTA is a chelating agent. It binds the divalent cations like calcium, magnesium, and iron that bacteria typically need for biofilm formation and that drive coagulation within the catheter lumen. The concept is not new. Smaller observational studies had suggested benefit, but critical care practice does not change on small studies. What was needed was a pragmatic, blinded, real-world trial in ICU patients. Ornoska and colleagues at 6 Canadian hospitals delivered exactly that. Published in JAMA, this was a pragmatic, triple-blind, multi-center, cluster randomized crossover trial. 6 ICUs were randomized to use either 4% tetrasodium EDTA or a control locking fluid, saline for standard catheters, 4% citrate for dialysis lines, reflecting current standard of care. Each ICU used one fluid for 3.5 months, then crossed over for another 3.5 months. 1,468 patients were enrolled in the final analysis. The mean age was 60 years. 38% were female. The cohort had predominantly triple lumen central venous catheters at 66%. The primary outcome was a composite: central line associated bloodstream infection, catheter occlusion requiring alteplase, and catheter removal due to occlusion. The incidence was 13.1 events per 1,000 catheter days in the EDTA group versus 19.9 in the control group, with an adjusted rate ratio 0.68. The adjusted absolute rate reduction, 5.1 per 1,000 catheter days, with a number needed to treat of 20. Breaking down the composite is important. The result was driven primarily by a significant reduction in alteplase use. 66 versus 112 occlusion events requiring thrombolytic administration. The rate ratio was 0.66. The CLABSI component had only 2 versus 3 events, numerically in the right direction, but far underpowered to reach significance on its own. The trial was not designed or powered to show CLABSI reduction in isolation. 2 findings deserve honest acknowledgement. Colonization events were numerically higher in the EDTA group, 11 versus 5. Not statistically significant, but a signal worth watching as the practice scales. And the hemodialysis catheter subgroup showed no benefit, trending in the opposite direction. Dialysis lines represent approximately 10% of catheter days in this trial. For that specific subgroup, the data do not support a change. Safety was clean. No adverse events. No clinically significant hypocalcemia. Calcium increased modestly in both groups equally over the ICU stay. So, what this means at the bedside? If your ICU locks central venous catheters with saline or heparin, this trial gives you the evidence to switch to 4% tetrasodium EDTA. The intervention requires nothing more than changing the syringe. No change in patient management, no monitoring burden, No additional cost relative to recurrent alteplase use. What I would not do yet is apply this to hemodialysis catheters. The data show no benefit in that subgroup, and a dedicated trial is needed before extending the practice to dialysis lines. So what's the takeaway? 20 central lines locked with tetrasodium EDTA may prevent one composite complication, a practice change that costs nothing but the right syringe. You have a patient with non-cystic fibrosis bronchiectasis. 2 exacerbations last year. Computed tomography confirmed bilateral airway dilatation, Pseudomonas negative. She asks directly, should she start azithromycin? A colleague has her on it already. Another colleague is asking whether brensocatib, the DPP1 inhibitor that just received FDA approval, would be better or could be added. What do you actually know? The challenge with bronchiectasis pharmacotherapy has never been a shortage of drug candidates. It has been a shortage of direct comparisons. We have had macrolide data from Embrace, Bless, and BAT. We have DPP1 inhibitor data from Willow and Aspen. But how do these agents compare against each other? Yamamoto and colleagues pooled 31 randomized controlled trials, 4,092 patients, and 8 anti-inflammatory agents into a network meta-analysis, published in Chest in June 2026. The primary outcomes were rate of overall and severe exacerbations. Secondary outcomes included time to first exacerbation, quality of life measured by the St. George's Respiratory Questionnaire, lung function, and adverse events. Grade certainty ratings were applied throughout. The coherent signal across the network is this: 2 agents work. Compared to placebo, long-term macrolide antibiotics reduced overall exacerbation frequency by 56%. DPP1 inhibitors reduced it by 27%. Everything else, including inhaled corticosteroids plus long-acting beta-2 agonists, CXCR2 antagonists, PDE4 inhibitors, and statins, showed no consistent benefit. Within macrolides, azithromycin showed the largest and most precisely estimated reduction, with a rate ratio of 0.37. Erythromycin followed. Roxithromycin carried a wide confidence interval that crossed 1. For severe exacerbations, DPP1 inhibitors maintained a statistically significant reduction with a rate ratio of 0.70. Macrolides trended toward benefit, but the confidence interval crossed 0. So, we can say macrolides reduce overall exacerbations with confidence. We cannot yet say they reduce severe exacerbations with the same confidence. A subgroup finding from this network meta-analysis deserves particular attention at the bedside. The benefit of DPP1 inhibitors was entirely consistent regardless of whether patients were on background macrolide therapy. Brensocatib works as monotherapy, and it works as add-on therapy for patients already on azithromycin. Quality of life, though, did not improve meaningfully for any agent. The editorial published alongside this paper calls the findings important but incomplete. The central argument is that the field cannot remain in a one-size-fits-all approach. Endotype data were largely absent from the included trials. The author also raises the non-tuberculous mycobacterial concern around macrolides directly. Before prescribing long-term azithromycin, rigorous non-tuberculous mycobacterial screening is not a formality. It is a clinical necessity. What this means at the bedside. For patients with 2 or more exacerbations per year, azithromycin remains the most effective anti-inflammatory option. Brensocatib is a legitimate alternative for patients with macrolide contraindications, including Pseudomonas colonization, non-tuberculous mycobacterial concern, and QT prolongation, and can be added on top of azithromycin without losing its effect. What I would not do is prescribe inhaled corticosteroids for bronchiectasis exacerbation prevention. The evidence consistently shows no benefit, and the safety signals for non-tuberculous mycobacterial infection and pneumonia are real. So what's the one-line takeaway? Azithromycin cuts exacerbations by more than half. Brensocatib cuts them by more than a quarter, and they work independently, so the answer may simply be both. Let me use this one to teach something. A colleague calls from the medical ICU. Postoperative day 3 after repair of a perforated bowel. The patient is febrile to 40 degrees. Vasopressor requirements are increasing. Blood cultures have been sent. The question is simple. Should we start antifungal therapy? Most of us answer this question using the wrong framework. We ask, do we have proof of candida? The better question is, does this patient have a pathway that allows candida to become invasive? Because invasive candidiasis is not primarily a microbiology problem, it is a pathophysiology problem. Candida lives harmlessly on our skin and throughout the gastrointestinal tract. In healthy patients, it is a commensal organism. It coexists with the microbiome and rarely causes trouble. Critical illness changes that balance. Broad-spectrum antibiotics wipe out competing gut bacteria. Sepsis increases intestinal permeability. Abdominal surgery disrupts physical barriers. Central venous catheters provide direct access to the bloodstream. Parenteral nutrition, renal replacement therapy, mechanical ventilation, transfusions, and immunosuppression all increase risk. Think of invasive candidiasis as requiring 3 steps. First, colonization. Second, barrier disruption. Third, dissemination. Once those 3 events occur, candida stops being a harmless passenger and becomes a pathogen. And that is why the classic patient is not someone with community-acquired pneumonia. It is the patient with prolonged ICU exposure, recent abdominal catastrophe, multiple antibiotics, central lines, and ongoing sepsis. Now let's discuss the diagnostic trap. Most clinicians treat blood cultures as the final answer. But blood cultures are remarkably insensitive. Sensitivity is only about 50%. In deep-seated disease, the performance is even worse. Results may take 2 to 3 days. So a negative blood culture does not tell you that invasive candidiasis is absent. It only tells you that candida was not recovered. Those are not the same thing. The most common deep-seated manifestation is intra-abdominal candidiasis. And importantly, only about 14% of patients with intra-abdominal candidiasis have concomitant candidemia. That means many patients with clinically important candida infections will never have a positive blood culture. This is where biomarkers and molecular diagnostics become useful. Beta-D-glucan has a sensitivity around 81%, but specificity is only 60%. The mistake is ordering it and treating a single positive result as a diagnosis. Abdominal surgery, septic shock, dialysis, albumin administration, blood products, and intravenous immunoglobulin can all cause false positives. The test works best when interpreted in context and when 2 consecutive positive values are obtained. The more interesting test is T2 Candida, 91% sensitivity, 99% specificity, direct detection from whole blood, results in under 5 hours. And unlike many other tests, prior antifungal exposure appears to have minimal impact on performance. For many ICUs, this remains one of the most underutilized fungal diagnostics available. Now let's talk about the mistake on the other side of the equation. If blood cultures are insensitive, should we simply start antifungals in everyone at risk? The answer is no. And this is where stewardship matters. The Empiricus trial evaluated empirical micafungin in critically ill patients at high risk for invasive candidiasis. Mortality did not improve. Current guidelines therefore recommend empirical antifungal therapy primarily for patients with septic shock and significant candida risk factors. Not every patient with a central line. Not every patient on broad-spectrum antibiotics. Not every patient with persistent fever. The goal is targeted suspicion, not reflexive treatment. Another important teaching point. Many clinicians know the Candida score. Many know the Ostrowski-Zeichner score. Few know their greatest strength. Their positive predictive value is poor. Their negative predictive value is excellent. These tools are often better at telling you who probably does not have invasive candidiasis than identifying who definitely does. When candidiasis is confirmed, management becomes straightforward. Start an echinocandin, micafungin, caspofungin, anidulafungin, or the newer, once-weekly echinocandin rezafungin, approved in 2023. Then, remember the intervention that costs nothing and may save a life. Remove the central venous catheter. Candida forms biofilms. Failure to remove infected catheters is associated with higher mortality. Once the patient is hemodynamically stable, blood cultures have cleared, source control is achieved, and the isolate is fluconazole susceptible, step down to oral fluconazole. Continue treatment for 14 days after documented bloodstream clearance. And one final point, the epidemiology is changing. Candida albicans still dominates, but non-albicans species now account for an increasing proportion of disease. Most concerning is Candidiasis auris. The WHO lists it as a critical priority fungal pathogen. 90% of isolates are resistant to fluconazole, 30% are resistant to amphotericin. It persists on surfaces, spreads between patients, and has already caused healthcare outbreaks worldwide. For Candida auris, echinocandins remain first line. Oral azole step-down is generally not recommended. So what does all of this mean at the bedside? Don't ask whether Candida has been cultured. Ask whether Candida has been given an opportunity to invade. A patient with abdominal catastrophe, antibiotics, central lines, and ongoing sepsis is telling you a story. Blood cultures are only one chapter. Invasive candidiasis is not diagnosed by a positive culture. It is recognized by understanding risk, using smarter diagnostics, achieving source control, and treating early when the probability becomes high enough. The blood culture is not the diagnosis. The patient's biology is. 3 studies. 3 completely different clinical problems. 1 common lesson. In medicine, some of our most persistent errors come from assumptions that were never deliberately re-examined. We assume a syringe is just a syringe, until a simple design change prevents catheter complications. We assume controlling inflammation in bronchiectasis means choosing one therapy or another, until evidence shows some patients may benefit from both. And we assume a negative blood culture makes invasive candidiasis unlikely, until we remember that the organism does not always read the textbook. Good clinicians do not just learn new treatments, they learn when old assumptions stop being true. If this episode gave you something to rethink in your own practice, share it with a colleague. These conversations spread one clinician at a time, but they change patient care far beyond a single bedside. Thank you for listening to This Week in Pulmonary and Critical Care Medicine. Until next week, stay curious and keep questioning the obvious.